Today, I'm delighted to be joined by Bita Manzouri. Now, Bita is a consultant ophthalmologist with an internationally influenced career, a strong refractive and cataract practice, and a reputation as both a formidable surgeon and a brilliant communicator. And of course, she's shortly due to take on the role of president of the UKISCRS. Bita's known for her passion, her clarity of thought, and infectious energy, and she's someone who challenges complacency while still keeping the room laughing. Bita, thank you so much for joining me.
Thank you very much for the invitation, Simon.
Now, Bita, you've had a fascinating career to date, shaped by both general medical and ophthalmology training, refractive surgery leadership. Looking back, what experiences most define the surgeon that you are today?
Oh, I think they were the experiences that gave me the greatest amount of discomfort and put me out of my comfort zone. Um, One example was a period in my training when I was working with a consultant who wasn't particularly sympathetic to the fact that I had quite an extensive period of time out from surgical training and that I had a young family and I was working full time and I had to juggle working full time and running a household. And he would do things like not let me operate, do any intraocular surgery when he was away, even though I was quite senior in my training at that time. And that kind of fed into the lack of confidence that you felt when you came back after a period of training. And so I thought, if he's not going to teach me, I have to learn by observation. And to give credit where credit is due, he was a beautiful surgeon. And I watched him and I learned from how meticulous he was, which fed my own OCD. And I made sure that I became the surgeon that he wasn't helping me to be.
Very nice too. So, people often describe you as both technically formidable but great fun too. How important is personality in surgery, or does it all vanish when the microscope comes down?
Wow, technically formidable. I have to thank the person who said that. um,
Very
person,
much a compliment.
Thank you very much. Personality in surgery, I think it reflects how you handle stress in life in general. And I think the true personality of someone it shows when the microscope does come down and when you do run into trouble. Are you the kind of surgeon who stays cool as a cucumber under those circumstances, or are you as hot as a chili when things go pear-shaped? So I think personality is very important, and you really get to see the true nature of a person when they're under stress. And there's nothing more stressful than an operation that is not going to plan.
So, are you a cucumber or a chili?
I'd like to think of myself as as a cool cucumber, but I think you have to ask my trainees. They would be a better judge, I think.
Now, as incoming president of the UK ISCRS, congratulations first of all.
Thank you.
But a question about that: what do you think the UK cataract and refractive surgeons need more of, and what do we need to stop doing?
Okay. So I think independent sector practice is here to stay for the foreseeable future. And I mean, that's especially true having read the manifesto of the incoming college president. And I think we need to start blurring some of the lines that exist between NHS hospitals, NHS care that's provided in an NHS hospital, and NHS care that's provided by an ISP. For example, I have a very good friend who is one of the training directors at Optegra, and they're very keen to engage trainees. They're very keen to let trainees operate with them and learn from them. But the deaneries are less willing to let the trainees go to them. And I'm not quite sure I understand the reasoning behind this decision. So I feel it's such a shame, it's such a missed opportunity because in the end, isn't our aim to train exceptional surgeons? And does it really matter what path they take to become exceptional?
Yeah, I mean, there are certainly examples from around the country where an awful lot of ISPs are having trainees. It may just be a local thing, but the more
Yeah,
we do, the better.
I mean, it is definitely local in our area, but this colleague of mine is based in the Midlands. And
Mm.
she says she's really struggling to engage the local hospitals in the training opportunities that they provide.
Yeah, certainly very frustrating. Do you
Yeah.
think UK ophthalmology in general is ambitious enough compared to Europe and beyond, technically, culturally, commercially?
In the private sector, absolutely yes. In the NHS, sadly, no. I think cost and managerial interference inhibit curiosity and innovation. For example, I wanted to get a particular device to undertake a particular form of corneal surgery in our trust. And my goodness, the form filling, the committees, the cost justification, the meetings held to discuss the product by people who don't understand the product, it just makes you lose the will to live. Whereas you don't have any of those inhibitions in the private sector. You want to try something and you just go ahead and do it. One classical example was ISBCS. I was a very early adopter of this technique since my mentor at the time was also an early adopter. I presented at numerous meetings on the benefits of ISBCS. And I remember one particular meeting, which was quite embarrassing. It was at ESCRS, there was a convention on ISBCS. And we went very proudly presenting the 140 cases of ISBCS we've done. And we were followed by some surgeons from India who presented the 40,000 cases of ISBCS that they had done. And you just thought, we are so far behind. So it was a shame, but it was a very humbling moment.
Just for clarification, for any non-medical listeners, ISBCS, of course, is immediately sequential bilateral cataract surgery.
Yeah.
So, Peter, if there is one thing that you could change that's entrenched, an entrenched habit, if you like, in UK ophthalmology, if you could change it overnight as the new president, what would it be?
Um, I think it has to be something practical because changing mentality and people's ideas is not something that can happen overnight. So something very small and practical that can be done overnight has to do with sustainability practice. Um, I have had the privilege of working abroad and doing some charity work, and they are very limited by the resources they have. And you see how they manage to practice, and yet their rates of infection after surgery are very similar, if not better, to the rates we have here. One practice, for example, would be the use of a drape. We're operating on a small area, the eye, and yet the patient gets covered in a whole body drape. Whereas when we were operating in Cambodia, for example, they have a drape that is literally this big and it works perfectly well. It does the job it's supposed to do. So it's a very easy change. It's a very good change. It's a sustainable change, ticking the sustainability box. And I just think, oh, we have a lot to learn from the third world. It's not just us who are the leaders of innovation. They do a lot of good things. And I think with a great deal of humility, we have to accept that we can learn from them.
We've certainly inherited an awful lot of things, haven't we? Wearing gowns, huge drapes, sterile air. Do you
Yeah.
think we actually really need gowns on for cataract surgery and sterile air?
I think it's good to have a gown on, but I don't necessarily think you need to change it between every patient. If you have a list, an all-day list, the gown doesn't hardly touches the patient. Um, I think changing gloves is a very good idea. Um, even the concept of you wash your hands, you put on one pair of gloves, then you alcohol sterilize the glove. I don't think that is unachievable. I don't think that's not, I don't think that's a bad idea. Um, so there's a lot that we can learn. One of the places I visited, our nurse would set up the scrub trolley next to the bed and you would use the instruments you would use and you would pass them on to be sterilized, but you didn't change the scrub trolley. You then went to a buffet system of instrumentation, picked up what you need for the next case and brought it across and used it. How much does that save in terms of instrumentation that are not used and wasted every time you perform an operation? How much does that save in terms of the drapes over the trolleys? There's just so much we can learn.
Let's move on to more premium technology, if that's okay. So, premium lenses and refractive cataract surgery still provoke some strong opinions from certain people. Where do you think we most commonly fail patients and how we explain these options?
Consent. I think refractive lens exchange will always have shortfalls at the moment. There has to be a compromise somewhere. You want to be spectacle independent. You have to understand that perhaps the quality of your vision will not be as good if you go for a multifocal lens as you go with a monofocal lens. And I just feel that the patients feel that their expectations are not met because they have not understood everything that was said to them. They'll sign the consent form, they'll initial next to the fact that they're going to get halos and glare, but I don't think they understand the practical manifestations of what halos and glare would mean for them. So I believe in chair time. I believe in giving patients time to reflect and to question. And the number of times the patient comes back to me and says, Doc, I have this symptom which is annoying, but you did warn me about it. And I know I chose the surgery. That gives you a lot of satisfaction, knowing that you spent time making them understand the practical implications of where they're going to have to compromise to achieve their goals. So consent.
Do you believe in seeing people in advance of the day of surgery? There are people who are proponents of a see and treat, in other words, meeting patients for the first time on the day of surgery.
Um, I I don't think it's necessary to meet this patient before the surgery, as long as you have systems in place that explain the surgery to the patient and they have time to reflect and come back and ask you questions. I think training in taking consent, that whole pathway, if it's watertight, if it's really well structured, then there's no reason to see the patient before the day of surgery. I do object to surgeons who have never seen the patient. The patient gets worked up by someone else in the lead up to surgery, especially when you have pooled lists, for example. And on the day of surgery, they do not look at the patient beneath a slit lamp before they operate on them. I think that is just unacceptable, absolutely unacceptable.
And you do a fair bit of medico-legal work, I understand. So
I do.
you presumably encountered that situation before, have you?
A lot of the time. And, going back to that answer about consent, you get a lot of patients who come back who have refractive lens exchange and they want the holy grail. They want to be spectacle independent. They want to have fantastic contrast sensitivity. They want to have a great quality of vision. And there is a compromise. You have to, I went to a conference at the weekend and this surgeon was talking about refractive lens exchange. And he was saying you have to make patients understand if you want to be spectacle independent, that comes at a cost. And that cost may be that you have halos and glare, which may stop you driving at night, but then you are spectacle independent the rest of the time. So what is it that you want? And a lot of unhappy patients are patients who feel that they were taught about halos and glare, but they didn't understand the practical implications of what halos and glare and contrast sensitivity diminishing in low light conditions means for them.
Let's talk a little bit about that sort of the tightrope between the NHS and private practice. So just imagine you're sitting in an NHS clinic and a patient asks you about private options. You obviously have to be absolutely whiter than white, informative, but not promotional about your own services, all while imagining the patient might be an undercover reporter. How
Yeah.
do you personally navigate that conversation?
I think if you are going to give the patient proper informed consent, it's very important that the patient knows all of the available options, all of the options that are available to them. So you have to let them know that in the NHS, we put in monofocal lenses, but there are better quality lenses that are available in the private sector. And I personally see a patient, I let them know of the choices that are available. The vast majority of patients who see you in the NHS are very happy to take what the NHS offers. But if a patient does express an interest in pursuing or at least sort of looking into premium lens surgery, then I recommend other surgeons to them. I never recommend myself. It's only when the patient turns around and says, "Do you do this kind of surgery?" that I would then say, "Well, yes, I do." But at the same time, there are other people, so don't feel that you are obliged to come and see me. Um,
It's an
so
incredibly honest approach.
I think you have to be. I mean, I don't understand why someone wouldn't be.
Yeah.
You know, I
Particularly as there could be an undercover reporter there. You never know.
yeah, with my medical legal hat on and seeing the experience of patients under different circumstances, you learn a lot and it influences the way you practice your medicine.
Do you think it's possible to explain the private options properly without implicitly nudging patients towards them?
Yeah, I think it is. And I always say to patients, you can have premium lens surgery, but there are their own risks. There are certain risks associated with those. And if you want to explore them, you need to see someone who can explain all of those risks to you. So I don't want to push you towards premium lens surgery thinking that's the holy grail of spectacle independence and you're going to have a phenomenal result because it's a premium lens. There are shortfalls even in premium lens technology. So you have to make a decision as to what it is that you want from your surgery. And, I think the vast majority of patients who attend an NHS clinic are very happy to accept a monofocal lens. And most patients want to have good distance vision. And another advantage, I guess, in the current NHS is that increasingly more and more trusts are offering monofocal plus lenses so that it gives the patient a certain amount of intermediate distance vision. And in this world, well, in our world is moving away from distance vision to the intermediate distance. So they're actually getting even a benefit on the NHS.
So, Peter, if you needed cataract surgery yourself tomorrow, and I'm sure you don't, which lens would you choose to have implanted? And what would matter most to you in that decision?
Um, well, I actually like my glasses. I quite consider them a nice fashion accessory. And I have a son who's quite myopic. And he always says to me that when he takes off his glasses, it's a good way for him to switch off at night because he can't see anything. So, you take off your glasses or you take your lenses out and you have no option but to go to sleep. So I'm not one of those people who feels I would benefit from premium lens surgery. However, having said that, I absolutely cannot stand reading glasses. I cannot stand wearing glasses for near vision. So for me, I would probably go for a lens that gives me the best quality of vision, which for me would be a monofocal lens or a monofocal plus lens, and probably a target refraction of -2. So I have good near vision and I'm very happy to continue to wear my glasses for distance. On a day-to-day basis, I will admit that I actually use monovision. I use a lens in one eye to give me good distance vision, but I don't like monovision. I use it because it's practical, it's easy when you're operating, when you're using the slit lamp, but as soon as I come home, I can't wait to get that lens out of the eye.
And would you go hydrophobic, hydrophilic, yellow tint, clear? What's your choice?
So I would definitely go hydrophobic because I don't think you can predict what the future holds for you in terms of what your ocular pathology is going to be. You may get trauma in the eye, you may end up with a retinal detachment, you may require gas in the eye, and there is a risk of hydrophilic lenses becoming opacified, which adds another complexity to an already complex situation. So definitely hydrophobic. I would go for a clear lens because I'm not convinced that the yellow tinted lenses offer any advantage over a clear lens. Um, aiming for a -2 refraction.
Sounds very
Um,
precise.
and
And who would you ask to do your procedure for you?
oh, that's a very good question. I have someone in mind, but I'm not going to drop the name. But it has to be someone who I know is a good enough surgeon, but not someone who is um, someone who you socialize with and have a much closer relationship over and above a professional relationship, because it's just unfair to put that kind of stress on a close colleague. Um, Sarah Mailing, who is one of the council members of UKISCRS and a fantastic surgeon, said to me, you know, Bita, when you sort of drape the patient up and you look down the microscope, it's an eye, and all eyes are the same. And I said to her, Sarah, I don't think I've quite got there yet because I'm still under the stress that I know this person and I can't afford for anything to go wrong with them.
Yeah.
They have trusted me with that surgery, and that in itself is a great honor. So I can't detach myself quite to the same extent as she was describing.
No, I totally understand. So, fantasy IOL time. I'd like you to design your own lens if you like. I want you to use and mix and match freely. For example, an injector system from one company, a square edge from another, the optics from another. What is your sort of ideal lens that you would put together? What's the Manzouri lens based on everything that's out there at the moment?
Um, So let's go through injector. I haven't used it, so it's a little bit unfair, but I've heard the Bausch& Lomb injector is really good. So I'm going to go with everyone's word that the Bausch& Lomb injector is very good. Square edge design, and I really like the frosted edge that J&J do, because the frosted edge of the lens provides that extra layer of friction between the lens and the bag, helping lens stability. We've already talked about hydrophobic material, so because you just can't predict the future, and I just don't want that layer of complexity with hydrophilic materials. And I mean, I have said I'm not a great fan of the multifocals, but I have recently been very impressed with the optics of the J&J Eyehance, which is a monofocal plus lens, as well as their Odyssey, which is a multifocal lens. Um, I also believe in a single piece lens, and I would request the surgeon to do what I do, which is to place the haptics horizontally, because apparently that is supposed to reduce negative dysphotopsia, that sort of black little, that feeling of black crescents in your vision that some patients experience. Um, Anything else?
So that's
Oh, and a single piece lens.
yeah. And just out of interest, would you have bilateral surgery yourself, or would you prefer unilateral sequential?
I've got to put my money where my mouth is. So I would put ISBCS, but it would have to be a general anesthetic. I'm just too scared. And I'll probably be holding my breath, thinking, are they going to ask for the vitrector now? So put me out, do both eyes, wake me up, tell me it's over.
Can you imagine hearing that noise halfway through?
Yeah, exactly, exactly. I just can't.
No. So, Peter, you're a powerful speaker and a very visible role model, particularly with your new presidency coming very shortly. How much has your background and heritage shaped your confidence and leadership style?
Um, my background and my heritage. I think I don't think my background as such has shaped my leadership style because, for all intents and purposes, I've grown up in the UK and I'm very familiar with um, the UK teachings and learning. Um, I spent a few years in the US and I obtained my high school diploma in the US. And I had some exposure to public speaking there, which really built up confidence to be able to speak in front of an audience as an adult. So we had something called forensics. Forensics is not as morbid as it sounds. It was a public speaking club that we did at the weekends, and you would go to various competitions and you could choose various categories. So you could speak about a special occasion, or you could do an 8-minute speech on a topic of your choice, or a 4-minute speech, or recite a piece of poetry, or recite a piece of prose. And you would go from competition to competition, sitting in front of complete strangers and saying what you have chosen uh, to quote. And that gave a lot of confidence of being able to speak in front of an audience of complete strangers. So that was really fantastic experience. And it's such a shame that we don't have something equivalent to that in the UK. Um, I think the other part of me that has shaped who I am is being a woman in a subspecialty that has traditionally been in the past, and at least during my training, very male dominated. You have to be that little bit more feisty. And, you know, you have to make sure you're not behind. And you have to do all of that at the same time as you're juggling raising a family and the responsibilities you have towards your children and your spouse. So, yeah, it hasn't been an easy path. And a lot of the times you feel you walk in a tightrope, and it just takes a little gust of wind, whether it's, a child having a temperature just about as you're about to leave the door, to upset everything. So yeah.
I sense your greatest days are still ahead of you, though.
Oh, that's very kind. Thank you. We'll see.
Now, Bita, if you weren't an ophthalmologist, what would you realistically be doing instead?
Are you asking me in the medical profession, or are you asking me outside of the medical profession?
Driving motorbikes, whatever you want to do.
If, well, I think it depends what stage of your life you ask me that. So if I had to go back 20, 25 years ago, would I do ophthalmology again? Uh, that's a good question, because ophthalmology at the time I chose to go into it ticked all the right boxes for me. I actually wanted to be a head and neck surgeon. That was my first love. I loved the complexity of the neck, and I remember being a house officer, and I was working on the surgical firm at UCL, and we had one female registrar amongst all the male surgical registrars. Her name was Rachel, and Rachel was not only the most capable of all the registrars, but she worked the hardest. She would come in at 7 o'clock in the morning, she would go home at 10 o'clock in the evening. She was a superb surgeon, yet she wasn't always given the same opportunities that some of her peers were given. And I remember going home one day and sitting around a dining table with my parents. And the dining table with my parents has traditionally been a place where a lot of my problems have been solved. And I remember recounting this to my family, and my father said, "Well, have you ever thought about ophthalmology?" Ophthalmology is very technical, and yet it's very delicate. The lifestyle is much more suitable to you as a woman. And admittedly, I really enjoyed the 3 weeks of ophthalmology as we would do at that time. So I thought, yeah, maybe that is what I want to do. So ophthalmology at the time ticked all the right boxes for me. I was recently presenting at UCL and to a group of medical students, and they asked me the same question. And I said, if I had to go into ophthalmology now, I would perhaps take a little while longer to think whether it was the right specialty for me, because ophthalmology has changed a lot. It has become much more virtual. So a lot of the patient face-to-face contact has been taken away, and I really enjoy the face-to-face contact. There is a potential that a lot of what we do may become automated in the future. Um, so I would have to think again. If I didn't do ophthalmology, I really like interventional radiology. I think the skills that are required for that are really good and very technical. And again, it's a technically challenging yet stimulating um, area of specialization.
And a
If I
huge
wasn't
amount of innovation as well at the moment, isn't there?
exactly, exactly. And if I wasn't doing science, if I wasn't doing medicine at all, I think I have such a thirst for art because being so science focused for, the entirety of your adulthood from the age of 16 when you chose your A levels and they were all science based to medical school, it's always been science, science, science. And I love art. So the aim is in retirement to go and study for a degree in the history of art. So I'll probably do something arty.
Finally, what excites you most about where ophthalmology, cataract, and refractive surgery is going to be 5 years from now?
Um, Simon, I'm not sure 5 years is enough time to answer that question. I think one of our greatest achievements is going to be personalized patient care through technologies such as AI. I think better preoperative assessment of patients and this AI-driven planning tools will allow surgeons to better tailor the treatments more accurately to suit a particular patient, their anatomy and their visual needs. And hopefully that leads to better visual quality and fewer postoperative symptoms. I think one of the really exciting areas of ophthalmology is robotic cataract surgery. That's in the past been dismissed a lot, but I have one of my trainees who's currently studying for a PhD in robotic surgery. And he was saying to me that the current PCR rate of the current robots is 5%. Now, that's equivalent to an ST1
Mhm.
trainee PCR rate. And in reality, it's technically difficult, but a very reproducible surgery. And I think I think how I see the future panning out is that I think there will be a role for robotic cataract surgery in straightforward cataract patients. Um, I think what will then happen is that you will have specialist areas where you will have cataract surgeons who are going to specialize in the more complex cases. So you have surgeons who only do complex cataract surgery in specialist areas around the country where the more difficult patients will be referred to. So it's not something that's going to happen in 5 years, but I certainly think in the lifetime of an ST1 trainee now, that may well happen.
Change is the only constant, isn't it?
It is, absolutely. And it's quite exciting. When I was a child, I used to love sci-fi and I used to watch Star Trek. And if you remember Bones, the surgeon, the medic on board, if somebody went into the medical ward, he would take this device and he would run it over the patient and it would tell them what was wrong with the patient. I don't know if you ever watched Star Trek, but I loved it. And I was recently at a conference talking with a Polish colleague, and he said he had just been to China and he said that he'd seen this device where the idea was to set up these devices in supermarkets. And the patient would go up to the device, put their head in, it would scan their eyes, it would find out if or what is wrong with their eyes. And then right there and then, it will make an appointment at a specified date and time with a surgeon who has that specialist interest in their eyes. And so as you come away from the device, you get a printout of where you need to go, who you need to see, on what date and what time. And, how far away is that from that sci-fi from the late 1960s? So it's really exciting times.
Dr. McCoy would be proud. Yes, of course, I'm a fan. Bita Manzouri, thank you so much. It's been an absolute delight. I hope you've enjoyed yourself.
Oh, I have. Thank you so much for the invitation again, Simon.